Glad to see you all here today. I'm Teresa Wukasik. I'm the Executive Director of the HealthPath Foundation of Ohio. I think I know most of you here, but if I haven't met you yet, I will before the end of the day. So we're very pleased to have you here to join us in our second annual Community Connections Workshop. Thanks for being here today to share in this very special learning opportunity. We have some great speakers lined up for you today. And we'd also like to extend a very special thank you to the Workshop Planning Committee volunteers who helped plan this effort. And I know Mona Taylor is here from the Ohio Department of Health. Mona, if you'd stand, please. Thank you, Mona. Then also, the other members are not here yet, but they include Heather Porter from the Ohio Association of Community Health Centers, Lisa Hamler-Fugit from the Ohio Association of Food Banks, Kim Taplinger from Health Partners of Western Ohio, and Francie Wolgen from the Health Foundation of Greater Cincinnati. And of course, a very special thank you to our staff, Christine Mulvin, our program officer, who put in a great deal of effort in planning this today, and Tara Behannon, our administrative coordinator, who also helped. So please join me in thanking them for their efforts for today. I'd also like to recognize a very special guest who's with us today. Senator, I'm going to put you on the spot, Senator Capri Cafaro, who cares about health access. So we appreciate your concern and care for the citizens of Ohio. And also Shiloh Turner, who is the president of the HealthPath Foundation of Ohio. Big shout out for her too. HealthPath has invested over $14 million in our service area since we started grant making in the year 2000. And we really see this Community Connections project as a way for us to further reach out in our service area and provide additional funding for healthcare access. It's our intent to provide a grant in every one of the 36 counties in our service area. So we're very glad to see you here, and we appreciate your interest and look forward to the opportunity to work with all of you. I'm also very pleased to have our board chair here today, Gene King. Gene is the son of a physician and has worked on health law issues in Ohio for over 25 years. Gene is a graduate of the Ohio State University College of Law. He served as the managing attorney for the Ohio State Legal Services Association State Support Center, a position he held since July of 2009, when he became the director of the Ohio Poverty Law Center. Gene has served on the HealthPath board since 2007 and is currently our board chair. So I give you Gene King.
Thank you, Teresa. I spoke at the law school a couple of weeks ago, and someone informed me that, in fact, I had not graduated from the Ohio State University because when I graduated, it was before they started marketing the. So they've also sold the naming rights to the law school, so I lost on a couple of accounts there. So I'm very happy to welcome you here today, and to thank you for your interest in improving services to the communities across the state in need. And my job is easy today. I get to welcome you, I get to smile, cut a ribbon. The hard work is done by the HealthPath staff, and Teresa has introduced them, but she didn't get a shout out for herself and all of the work that I know she did. So on behalf of Teresa, Christine, Shiloh, and Tara, the board thanks you. And we recognize that we get to enjoy the results of your hard work, and we get to stand up and in the sunlight. So thank you very much. Running a foundation is a challenge, and we were talking before we convened about foundations and grantors not having enough money to do everything. And so in the HealthPath Foundation, we think about how to become more effective, how to use the small amounts of money to be more effective and to help Ohioans more. So after years of investing in building capacity in nonprofits, improving access in our service areas, and developing networks of advocates across the state, we thought that the Community Connections Initiative seemed to be a good next step to move HealthPath forward towards its goal of helping Ohioans achieve their fullest health potential. And that is one of our priorities, to help Ohioans achieve their fullest health potential. So instead of awarding large grants to a few organizations, the Community Connections Project allows us to reach more people and spread resources across a wider range of organizations. And the grants, we recognize, are small, but we hope that they are triggers. We hope that they are pivotal in your organizations. They allow you to use evidence-based practices that have been shown to work in other communities, and we hope that this broader-based approach provides more information about the most effective practices, so that as you provide services in your communities, we all learn how to provide better services to all our communities. Last year, we started Community Connections in Family Violence. We awarded $150,000 to 32 organizations in 28 counties to widen the use of evidence-based practices to prevent bullying, teen dating violence, intimate partner violence, and other forms of family violence. These grants are now midway in their process, but we're seeing very good results with them. So this year, we are turning our attention to preventative oral health and strengthening Ohio's safety net. Access to health care for anyone who's not been living in a cave is a hot topic. Right now, the Affordable Care Act is coming into swing, in some ways kicking and screaming, coming into swing. The Ohio legislature, with all due respect, Senator, is debating and debating and debating. I'm not blaming you. I'm right behind you. The Medicaid expansion. And we need to continue to build resources across the state to respond to these changes. Probably more than ever, access to health care and structures of health care are changing, and we need to respond to those quickly and effectively. We expect the Community Connection grants this year will again have a tremendous impact on access to health care by giving organizations resources to expand, by purchasing equipment, training staff, adding additional services such as dental or behavioral health, reach out to new clients, and even take services to patients rather than making the patients come to the services. You will hear about programs like these from many of the presentations today. I hope you will leave here with new ideas and new energy to continue the great work that you've all been doing. But first, let's put this in context. You may have heard, I assume you've heard, about the Navigator program provided by the Affordable Care Act. What are they? What role will navigators do? What role will health safety network providers like yourselves play in the process? The Medicaid expansion, whose fate is unknown. All of these questions will be answered today. And if they're not, come back tomorrow and we'll have the remedial session. Right? All of those answers and more will be given to you today. Before we start, we have two speakers to give us background and a forecast on the Navigators program. Jennifer Sullivan and Martine Apodaca of EnrollAmerica are speaking. Ms. Sullivan is the Director of Best Practices Institute at EnrollAmerica. EnrollAmerica is a nonprofit, nonpartisan organization whose mission is to ensure that all Americans are enrolled in and retain health care. The Best Practices Institute identifies, develops, and disseminates information on enrollment policies that will result in the most Americans enrolling in health coverage. Martine Apodaca is the Public Health Education Campaign Director at EnrollAmerica. He oversees the research, branding, strategy, formulation, and implementation of EnrollAmerica's national public education campaign aimed at enrolling millions of Americans in health coverage. I can't imagine a better goal for any of us to work on. Thank you all again for coming. Please join me in welcoming our first speakers, Jennifer and Martine.
hold it.
Do you just want to stay at the lectern? You
Sure.
promise not to wander too far?
I won't do my interpretive dance today.
Very good.
She's actually doing the first part. I'm doing the second part.
Yeah, you all will hear from Martine in a little bit. Okay, I will be right here. Good morning, everybody. How are you doing? Can I take a quick survey of the audience? I would just like to know a little bit more about who you all are before I launch into what I want to say today to make sure that it strikes the right chord for you. I know it's sort of safety net providers is the broad catchment term here, but are folks here from health centers, hospitals, okay, a little mix, other sorts of direct service organizations? Anything else shouted out if I missed it? Okay. Finance? Okay, dental clinics. Okay. Very good. Anybody else? Oh, public schools. Okay, terrific, terrific. An integral partner in enrollment. Okay, very good. Other key groups, especially we've actually had a lot of talk about that particular demographic and how that fits into enrollment. So I'm Jenny Sullivan, and I want to give you a little bit of an overview this morning of EnrollAmerica, where we're going, what we're doing. My colleague Martine is going to speak in a little while about specifically our public education research and how that's feeding into the broader campaign that we are planning to launch in the coming months. So actually, technically, it already is launched, but it was a soft launch. So anyway, and I apologize, I'm getting over a cold, so if I cough, I'm very sorry about that. So I can't imagine a better time for you all to get together to think about investing money and getting grants to do health outreach work or to do work to connect people to health coverage. The Affordable Care Act was a promise to get millions of people health coverage, but it's not a self-fulfilling promise. We have a lot of work to do to make sure that that all these people connect to coverage. And in case anybody wasn't aware of the ticking clock, we are 158 days away from October 1st. And what happens on October 1st? That's open enrollment. Open enrollment for the health insurance marketplace begins October 1st, and the coverage that people will get when they enroll in coverage starting in October will be effective starting January 1st of next year. If Ohio has a Medicaid expansion, then that might also be effective January 1st. But I know Ohio is by no means the only state that's still trying to suss out where it's going to land with the Medicaid expansion. So EnrollAmerica, as you've heard, is a nonprofit a national nonprofit, nonpartisan organization with the mission of maximizing the number of uninsured Americans who enroll in health coverage made available by the Affordable Care Act. Oh, thanks so much. Different states are going to choose different patchworks of coverage. We recognize that, and we are relatively agnostic. I personally am not agnostic, but I think as an organization, we just want to connect people to whatever coverage is available in their state. So we aren't at the forefront of fighting for a Medicaid expansion, but certainly if there's more coverage available, more people get enrolled, and we like that. So we do this in two main ways. My side of the world is really the policy shop at EnrollAmerica, the Best Practices Institute, and we're really working to identify, disseminate, share among partners the best ways to get this stuff done where the rubber meets the road. The other side of our world is really a national enrollment campaign, which you'll hear more about, as I mentioned, from Martine. But there's a lot of energy going into what actually happens on the field, what messages, what messengers are aptly placed to convey these important messages. So, and I'm sure some of you all have heard these kinds of talks before, so I hope I don't completely bore you. But just to get everybody on the same page, there are at least 15 million people who, according to the Congressional Budget Office, in their magical black box where they calculate what legislation will do, they think that 15 million people will enroll in coverage in 2014. Now, if we step back and look at how many people they think will connect to coverage over the next 10 years, this is almost half of the people that they expect to connect to coverage. They think it's going to happen in the first year. About half and half split between the people connecting to the exchange or the marketplace, I use those terms interchangeably, and another 8 million in Medicaid or CHIP, primarily Medicaid, because this is mostly adults, not children enrolling in coverage. But while this is just to say, this is an enormously high bar. And for better or worse, it's the bar that's out there. The Congressional Budget Office is the place of record that sort of sets the standards for are we achieving what the legislation we passed was intended to do? So this is going to be looming over our heads, and I don't necessarily think that we should feel bad if we don't make it to 15 million people connected to coverage. That's a very ambitious goal, and I'll tell you more about why that's so ambitious in a moment, but just to know that we've got our work cut out for us. So the paradigm for where we're headed with coverage is really moving from, as I mentioned before, sort of a patchwork of coverage where you've got this program for this population, this other bucket of coverage for another population, and lots of different rules, to truly a continuum of coverage where people can connect to, fill out one application and connect to whatever coverage that they're eligible for through one process, and that wherever they fit on the income scale, whether they're very, very low income or whether they're uninsured but they're working and they could have a relatively high income, that they're eligible for something. They're no longer left out because of a pre-existing condition or because of affordability barriers. Now, obviously, the Supreme Court threw us a bit of a curveball last summer, and this Medicaid, the bottom part of that scale, is in flux, but I think we will do our best to get people connected to whatever is available, and I think that if there are gaps, we're going to have to just think as a community about how we fill them, and I can't think of a better room of people that knows about filling gaps than this one. So when we talk about Ohio, again, this is just a little snapshot of what your current patchwork looks like. You've got children in Medicaid up to 200% of poverty. Then you've got where we're headed next year will be tax credits for those between 2 and 4 times the poverty level. 2 and 4 times the poverty level, and then folks above that level in the purple would be able to purchase coverage through the marketplace, but wouldn't get tax credits to do that. Pregnant women in the same place as children right now in Ohio. Parents, you do have parent coverage up to 90% of the federal poverty level in Medicaid. And you've got a little gap right there. That question mark on the blue shows you where, if Ohio were to expand Medicaid, those gaps would get filled. And then, of course, the green fills in with the premium tax credits and coverage through the exchange. So all of this is a certainty except for those blue spots. Those are where the potential gaps are. Otherwise, we know absolutely with 100% certainty that there will be a marketplace in Ohio and that there will be premium tax credits for people who fit in those sort of green bars. And as you can see, it's really, as you look across these different populations, a tremendous opportunity, particularly for non-parent adults or even parents whose children are older and no longer living under their roof. They don't have a lot of options at all right now, and they're going to move to a world where there are some significant options to connect them to real meaningful coverage. So then drilling even a little more closely into what the opportunity looks like in Ohio, there are just over 1.5 million uninsured folks. These are non-elderly uninsured in Ohio. And much like the national numbers, they are relatively evenly split between those who would be likely Medicaid eligible if Ohio expands Medicaid, and then the other half would be, most of them would be eligible for premium tax credits to get coverage through the exchange, and then a small sliver on the top who are uninsured would be able to get coverage through the exchange. They would just be paying the premiums completely themselves as opposed to getting a little bit of help with those premiums. So again, just to ground us on the opportunity. Enrollment isn't a snap. So like I mentioned before, it's great that we've created these programs. It's great that there's going to be premium assistance for premium help for people to get coverage through the exchange. But just making it available doesn't mean that they will know about it, doesn't mean that they will know how to enroll, doesn't mean that they will understand how to use that coverage once they have it. And I think just taking a quick snapshot of some other means-tested programs, national means-tested programs, you can see that these programs have been around for a long time. They're not launching in 158 days, and they don't have 100% take-up. 100% take-up is unheard of, really. People have the choice to do something or not. Now, what we don't have playing into all of these programs is an individual responsibility provision, which obviously has been the subject of a lot of attention in the news with respect to the Affordable Care Act. But nonetheless, getting to a healthy enrollment rate, Ohio has an 86.6% participation rate in children's Medicaid, I guess you all don't have CHIP. It has taken a lot of work, and I don't know if any of you have been working on getting kids enrolled in coverage, but there's been a lot of concerted energy, effort, and money put into making that happen. We want to make sure that the same effort is put into connecting all these new populations to coverage, and we're all in this for the long haul. Martina's going to talk a lot more about our research in a moment, but I did want to ground us in some of the major findings from our research. The biggest one that we use in every presentation we give is that more than 3 out of 4 uninsured Americans have no idea that the Affordable Care Act has anything in it for them, which might be hard to believe if you're living and breathing this stuff every day and intimately aware of all of the many changes. Maybe you're even overwhelmed by all of the changes. But your average American, particularly your average uninsured American, has no idea that anything's about to change. And this is where we come in. We have to make sure that we flip that number around. I'm going to talk a little bit more in a moment also about in-person assistance and how crucial it is that once we tell people, hey, there is coverage coming, they're interested, but based on past experiences trying to shop for health insurance, they're pretty sure they're going to need help. It does not sound like something that's easy or something they can just do on their own or click through on the internet. So having reliable, trusted, well-informed community sources to guide them through this process is going to be absolutely crucial. So a little bit more about the uninsured. I think as we're thinking about, at EnrollAmerica, about our campaign, about even our state assistance work, who we partner with, we have to take a long and hard look at who the uninsured are and where they live. Ohio is the number 8 state in terms of number of uninsured who live in the state, that 1.5 million we mentioned before. 2/3 of the uninsured are in just these 13 states here on the slide. Another thing that has been bubbling up recently, we've taken a closer look at county data, and I think you might find this interesting as well. Half of the uninsured, so there's just over 3,300 counties across the country. In just 115, you have half of the uninsured. Half. 10% of them are actually in 4 counties, none of which are in Ohio, which you'll be relieved to find out. But I will tell you that among those 115 where half of the uninsured live, 3 of them are in Ohio. And I'm betting you all can guess what counties those are, because you know Ohio better than I do. Any guesses? Cuyahoga? Hamilton? Yep. See? You all know. But this is why Ohio is absolutely part of really ground zero in our effort to connect people to coverage. There's just a very large volume. So then digging deeper, when we start to think about outreach strategies and who we're actually messaging to, you have to take a look at the demographics. And the demographics on this slide are national. They aren't specific to Ohio, but I pulled up the Ohio stats, and they're actually very similar, with the unfortunate exception that fewer folks are living in families with at least one full-time worker. And obviously Ohio has had some economic challenges lately. So there's 58% of Ohioans, uninsured Ohioans, live in families with at least one full-time worker. But otherwise, as you can see, this is a diverse group. We've got folks spread across the income level, although certainly given that affordability is one of the major barriers to connecting to coverage, a large portion of them are focused at that lower end of the income spectrum where they would be eligible for Medicaid coverage should it exist. When we look across racial and ethnic categories, although of course the largest number, particularly in Ohio, of uninsured are white, when you look at uninsured rates among specific racial and ethnic minorities, there are significant disparities. I think probably in this room we all have worked on that and are aware of that. But particularly among African Americans and Latinos in Ohio, we really want to make sure that we're going the extra mile to connect them to coverage, because they have some pretty startling disparities in terms of their uninsured rates. So. And then the difference between, frankly, I think the difference between men and women on here is interesting because it makes a nice graphic. I don't think it tells you that much about outreach strategies because who you message to might not be who you're actually trying to enroll in coverage. So it's not that we need to message to 53% men and 47% women. This is also just reflecting the fact, obviously, that Medicaid has been around for a long time and is more available to women than it is to men currently. So why are you all here today? Why am I so excited to be having the chance to talk with you? This is bread and butter. This is so exciting because you all are at the heart of moving these messages forward and getting people connected to coverage. This is obviously part of your core mission. People already trust you. You have the trusted relationships. You don't have to do research and figure out who these people are and figure out how to build bridges with them, because those bridges exist. You've built them and been using them for years. You have an opportunity now to fill in gaps. I think if you're doing direct service, you probably had the unfortunate circumstance of dealing with an individual who wasn't eligible for anything. And I think it is probably very exciting to think about having a different conversation with somebody come next year or come this fall. I've done some work in free clinics, and it was 10, 15 years ago, but man, I would love to go back and talk with some of those patients now and have better news for them. So, and then for the folks that come from the hospital community, you've got, in addition to sort of mission-driven incentives, you've got some financial incentives. Your dish is obviously, your disproportionate share of funding is decreasing. You've got increasing primary care rates for Medicaid, which is a little bit of a help if you're actually getting people into Medicaid. And then, of course, you've got community benefit requirements that you are possibly able to meet by doing some good outreach. So what does this all mean? I think hopefully I've convinced you there's a population out there, they need help, we want to connect them to coverage, but what does that actually look like? Fortunately, in addition to making more coverage available, the Affordable Care Act really turns on its head the system of connecting to that coverage. And there are some state choices, and historically there's definitely been a lot of state choices in terms of what it looks like to enroll in Medicaid or to enroll in another public assistance program. But really this is a matter of moving from the door on the right-hand side that is not particularly inviting, not easy to get into, and why would you even want to go through it in the first place, to a door that's accessible, open, friendly, and welcomes you in. And that's really the process that we're aiming for. So we do that by a number of things. And these requirements, I want to point out, are true no matter whether or not a state expands its Medicaid program. So these are true in Ohio no matter what. And they're going to be true not just for Medicaid coverage, but also for that marketplace coverage. So we're really building an integrated system where, although there's different funding streams and there's different pathways to coverage, individual families shouldn't have to know those distinctions. Those are meaningless. They want access to a doctor. They want access to health care, and we want to blur those distinctions as much as possible. So we do that in a number of ways. The Affordable Care Act does require a single streamlined application, as I mentioned before, so that somebody isn't applying for Medicaid, getting denied, and having to fill out a whole new application for the marketplace. They're filling out one application that then unlocks the door to whatever program they're eligible for. We're really simplifying how we count income. I won't get into the nitty-gritty of this, although I'm doing some breakouts later, and I'm happy to talk in greater depth. But basically, around the country, there are different rules about how you count income, who's in the household, all of that, and they really wanted to streamline that. So we've got some new sort of standards for how we count income that will be the same across the country and that will be more or less the same between Medicaid and the exchange. There are some nuanced differences, but we're getting rid of asset tests. Fortunately, I think that's already the case in Ohio. You don't have an asset test for Medicaid. Getting rid of any in-person interview requirements. Again, Ohio's ahead of the curve there. You've already done that. And then we're also requiring that states use electronic verification to the greatest extent possible. And this one, I know different states have been toying with and working with in different ways. I'm not sure exactly where Ohio is with this, but the notion is really the federal government in particular has a lot of information about us, whether we like it or not. And why don't we leverage that information to make our lives easier? Because it's already out there making our lives more complicated in many ways, right? Let's allow somebody to provide their social security number, which can then pull down their income information. It can pull down their citizenship verification or other immigration status information. And we can use that to get as far as we can in the application without requiring that individual to bring in a single piece of paper or attest, even in doing attestation. If we've got it in the system, we know it's true. Now, if it comes out of the system, you might ask, but what if it isn't true? What if it's not accurate? There is the opportunity, of course, for applicants to say, okay, this is what you know about me, but this, and this are not true, and let's correct those. And you absolutely get the opportunity to do that. So you're not being held hostage by your data, but hopefully it's helping make the process a little bit easier. And then this is just a visual to kind of show you what that sort of single streamlined process might look like. People will be able to apply for coverage online. Over the phone, and then obviously if they're applying over the phone, then that's someone on the other end of the phone is using an online module so they can generate eligibility decisions quickly. Or they can get in-person assistance to either sit with someone else who's filling it in online, or they can say, no, I really prefer paper, I trust paper more, that's what I want to do, and they can do that too. All of those are an option. Because of that sort of patchwork system and the way that we're mixing different categories of coverage, this visual also, maybe it doesn't do a great job of showing it, but you can easily have a family, and I just want to walk through this scenario quickly, where let's say you have a mom, a dad, and 2 children. Mom is pregnant. you can easily have a situation, and I guess Ohio will loop the kids with the mom there, but you can have a situation where the kids are eligible for CHIP, or here they'd be eligible for Medicaid. Mom's eligible for Medicaid because she's pregnant, and dad is eligible for the exchange. So it's just important to keep in mind that this system is crucial to getting everybody in one household connected to what program they're eligible for, because they're not all necessarily going to land in the same place. So you might be thinking this sounds a little complicated. It is complicated. And when we did our public education research this past fall, I think the stat actually was on one of my earlier slides, but 3/4 of those who will be newly eligible for some sort of help or some sort of coverage will want assistance to help connect to that coverage. They've had a lot of negative experiences trying to get coverage in the past, whether that's trying to apply for Medicaid or trying to keep their Medicaid, or trying to go on the individual market and getting denied for pre-existing conditions or not understanding the fine print. They've been in a really negative place, confused, overwhelmed, worried, feeling helpless, and the way that we turn those emotions around and get them to a place where they're feeling more secure, more confident, more reassured is to make sure that they have the help that they need to connect to coverage. If they're sitting alone in their living room trying to grapple through this and no one's there to toss them a lifeline, they might not make it through the process. They probably won't. And it's crucial that partners like all of you in the room know how to provide that help or make referrals to people who can. So just to dig a little bit deeper on our research, because you might think, well, people aren't connected. That one of the biggest barriers is that people don't have internet access. They're not online, and so of course they're not going to connect. Well, it's not actually true. And it feels weird to say that because that's my knee jerk as well. People don't have access. Of course, they're not walking around with smartphones, but a lot of them are. Smartphone use is obviously the lowest among these different indicators of sort of network, internet savvy. But and at the lower end of the income spectrum, people aren't as well connected as certainly as folks with more means. But across the board, people are more connected than I would have expected. But we went and asked them, okay, you're connected. So what does that mean? Do you want to go online and buy your health insurance there then? Not so much. People not really, they have the internet and they might want to go online and Google and explore and figure out, is this trustworthy, or who can provide me help, or let me just see if this is even something I want to go down the path with. But they're probably not going to sign on the dotted line online. They want to get in-person help. So a little bit more about what that, what kind of help they want. The two most important things people want help with, of course, are that eligibility process. Do I qualify for financial help and what kind? And then choosing a plan, because of course if somebody ends up, particularly in the marketplace, it's not one plan. There is going to be a whole panoply of different health insurance options, and they need to figure out which one works for them. And someone's got to help them figure that out. I don't know if any of you have a lot of plans to choose from. My employer has one now, but I worked for the federal government briefly, and there were 4 plans. And this is what I do for a living, and I found it completely overwhelming to try and choose one of the 4 plans. I went on my husband's because I didn't want to make a choice. So people want help also in person. It's going to be available over the phone. They hopefully will be able to get some sort of electronic assistance, whether that's through chat or through email. But by and large, even your kind of young folks who you think of as being really well connected are going to feel better about it if they're doing it in person, because this is such an important choice. It's not like buying a new pair of shoes or buying a plane ticket. Who do they want help from? The number one choice across across demographics was a state employee whose job it is to help, but I think the important part of that is the whose job it is to help. It's not so much that we need a new army of state employees, and I know that would ruffle some feathers wherever I went. But really the core of this is people want help from somebody who's trained to do this, who they can trust, who isn't trying to sell them one product or another, but who can be unbiased and walk them through and really give them the sense that they're getting the help they need. Martina's going to talk, I think, more later about what some of the different family members and what their role might be. Providers come in number 3 also across demographics and are actually more important among communities of color in terms of trusted messengers and somebody that they want to get help from. So that doesn't necessarily mean if you're in that provider role that you need to be a navigator or that you need to know all the eligibility rules, but you have to be prepared to answer questions because you're going to get asked, and you're not going to be want to be the one who's standing there and saying, yeah, I don't know, call this number. So that's hopefully what these last couple of slides will be, is to help you kind of think of your action plan. So I've kind of already talked about this, but the in-person assistance really gets people to where they need to be. It helps people understand their insurance, what is and isn't covered. It helps them understand that they've gotten through the process, that they know what next steps to expect so that they're not just hitting send on an online application and then twiddling their thumbs wondering when they're going to hear back. They have somebody who can be sort of their representative in the process and help them figure out where their application is and help them work through any kinks. So what are the state assistance options going to look like in Ohio? And your slide actually has an additional bubble in the middle for in-person assistance programs. I took that out on here because actually Ohio will not have an IPA, in-person assistance program, given the kind of exchange or kind of marketplace you all will have. In federally facilitated marketplaces, you will have navigators at the core whose job will be to connect people, help them walk through coverage. They will know how to do all of this stuff with the eligibility system and the application. There's $2.26 million on the line right now to be dispersed in grants later this year. And that application, let's see, the applications are due June 7th. So that RFP is out right now. But then wrapping around that, because that's actually not a lot of money, really at all. I mean, I know that you all are thinking about smaller grants today with the foundation, but even $2.26 million to connect 1.5 million people to coverage doesn't take long to realize that's really not a lot of money. It's what the federal government can afford right now. But we recognize that all of these other partners are going to be absolutely crucial to providing the assistance that's necessary. Certified application counselors are something that the federal government came up with in January this year. They came out with a new regulation and sort of created this new designation to say, we know that there are groups who are going to want to go through training, who are going to want to provide this assistance. We don't have money for you, but if you know you're going to be doing this anyway, you're in a provider situation or you're in the community and you know you're going to get asked these questions and you want to be prepared, become a certified application counselor. The federal government will be offering that training because of the kind of exchange Ohio has. In other states, it might be the state offering the training. And that will be another avenue that, like I said, doesn't come with money attached, but allows you to be a credible source in providing assistance. And then the other bubbles, obviously, are just other important partners who already help people today and who are going to continue to help people in the coming years. So I don't know if 158 days sounds like a long time away or like it's tomorrow, but what should you be doing in the next few months? This you're also going to hear more from Martine about. But I think when you think about the communications you have with the community, whether these are written communications, whether it's a one-on-one conversation, if you get asked about about health insurance and about the changes that are coming, these are 4 messages that across the board, one of these messages is the key message that every different demographic we looked at needs to hear to actually want to take those steps and get connected to coverage. So it's the notion that all plans have to cover certain benefits, that you might be able to get financial help to pay for your coverage, that you're no longer going to be locked out because of pre-existing conditions, and that all insurance plans have to show the cost and what's covered in simple, plain language without the fine print. Compelling messages that work across demographics that I would strongly encourage you to think about integrating into your materials, into your front desk staff and what they learn and the way that they answer questions about the new changes, and of course into anybody else who's out in the community talking with folks. And this is just a few other ideas, again, that we can talk about later in some of the breakout sessions when we talk about outreach plans, but it's really crucial that that all hands are on deck. There isn't a person in the room here today, I can tell you, who isn't going to be affected by the changes that are coming and doesn't have a role to play in helping people connect to coverage. You have data right now about the patients you're serving, the communities you're serving. Use that to your benefit. You already have those bridges. Figure out how you reach back out to those folks and make sure that they know what's changing. Develop a plan. It's nice to say you're doing outreach, but if you have a flyer in your waiting room, that's not really doing outreach. So think a little bit more proactively about what it means, what goals you want to achieve, who's going to help you achieve them, and what connections you might need to make with other community partners to really leverage all of your strengths. I'm not going to go into too much of these other ones right now, but I'm happy to answer questions. I think I'm probably heading up on my time. couple other things, just some resources that EnrollAmerica has to bear for all of you as you're thinking through this. We have both an in-person assistance resource center and a public education resource center. These are really clearinghouses of what's going on in other states. You can also search it by state if you know there's something in California that you really want to check out. Just a good place to look at what's going on around the country. Again, the sort of Best Practices Institute role in all of this is to be identifying these things and making sure that they're available to you. So check those out on our website. And then I know you're going to learn a lot more about mapping from one of the other presenters this morning, but I did want to promote a new tool that we just launched last week, which is state profiles and then state maps. So you're able to look at the non-elderly uninsured in specific geographic areas in your state. They technically are PUMAs, not counties, and I will definitely not get into the details of what that means, but you can look when you click on the area in the state, and it'll tell you which counties are included within the geographic boundaries of any given PUMA. And then it gives you the distribution of the uninsured by age, by income, by race, ethnicity, and of course tells you how many uninsured are in that area. So as you think about, the area the area that you serve, you get a much better picture of who might be eligible for coverage. So I think with that, I will pass it back. Oh, good. Oh, perfect. All right. Well, yeah. Who has questions? Anybody? Yes.
Forgive me for not already knowing the answers, but can you tell me a little bit more about EnrollAmerica, when it came to be, and how it came to be, and where the funding comes from?
Yeah, no, those are good questions. Happy to answer that. We've been around since the fall of 2011. We were formed, we were basically the brainchild of the executive director at Families USA. I don't know if you've heard of them. They're a national nonprofit consumer health organization for which I used to work a few years ago. And the thought was really kind of about our mission. Okay, we've passed this law, that's terrific, but how do we make sure that it actually works? How do we connect people to coverage? So our board and our advisory council are comprised of, we probably got well over 50 members on our advisory council now. But it's really any sort of enrollment stakeholders, or what I call them, any entities we could get to the table who have an interest in getting people connected to coverage, whether that's an altruistic reason or whether that's a financial reason. So that means we've got consumer groups, we've got health insurance plans, we've got hospital associations, we've got pharmaceutical companies, civic organizations representing specific demographics. We've cast as wide a net as we can, and I don't think we've said no to anybody who's knocked on our door. Our funding comes from our partners, as well as significant funding from the philanthropic community. So, does that answer? Okay. Any other questions?
Where do we go to get more information on becoming a certified application counselor? Where's that found?
That is an excellent question. It isn't available yet. The federal government is finalizing the rules on what the program is going to look like, and then they will be getting information out about the trainings later on this summer. What we have heard in sort of closed-door meetings with folks at CMS and CSIO, the entities running these programs, is that the training will be probably largely mirror the Navigator training. And we know that will be available sort of mid-August, that the grants will be awarded in, I think, August 15th is the date they're shooting for, and the training will be available after that. Certified application counselors, I can't imagine that they will have the training ready before then. So it's sometime between then and October. So. Any other questions? Okay, thank you all so much.
Oh, thank you, Jenny, for helping us navigate